Hello, I'm Sam Goldhaber, President of NATF, speaking to you today with Episode 2 of the Clot Chronicles. Today we're going to discuss the EINSTEIN CHOICE trial. This trial asks a very important question. How long should patients with pulmonary embolism and deep vein thrombosis be treated with anticoagulants? It might seem like a simple question, but in fact it's quite complex. In the olden days, the teaching was that 3 to 6 months of anticoagulation would be adequate, and that after 3 to 6 months of anticoagulation, it could be stopped, and patients would do well ever after. But now we know that if you stop anticoagulation following a deep vein thrombosis or pulmonary embolism and follow patients for the next 10 years, somewhere between 20% and 50% of the patients will suffer another DVT or pulmonary embolism. And these patients with a recurrent DVT or pulmonary embolism often have a more severe episode the second time around compared with the first event. So, to get into the EINSTEIN CHOICE trial, you had to be a European patient, and more than 3,300 patients were enrolled. All of them had received anywhere between 6 and 12 months of anticoagulation after a first episode of DVT or pulmonary embolism. Now, we divide pulmonary embolism and DVT episodes into two types. One type that comes out of the blue, that's considered to be an unprovoked or idiopathic event, and the other type that comes after something we can blame, such as surgery or birth control pills or major trauma, and those are called provoked episodes of DVT or pulmonary embolism. The unprovoked DVT and pulmonary embolism episodes recur at a much higher rate than the provoked episodes. But this trial, EINSTEIN CHOICE, had 60% of the participants with a provoked type of DVT and pulmonary embolism, and about 40% with an unprovoked out of the blue type of DVT or pulmonary embolism. And remember, they had been on standard anticoagulation for 6 to 12 months. They'd then go to their doctor and say, "What's next, doc? What should I do?" And in this trial, once patients signed up, they were randomized to receive one of 3 types of further treatment. They either got baby aspirin, which is 81 milligrams in the United States, but 100 milligrams in Europe, or they received the NOAC called rivaroxaban or Xarelto in a dose of 10 milligrams once a day. That's half the standard dose for treating DVT or pulmonary embolism. Or they received rivaroxaban in a dose of 20 milligrams once a day, which is the standard dose. And the patients were treated with one of these 3 regimens: low-dose aspirin, rivaroxaban 10 milligrams a day, or rivaroxaban 20 milligrams a day for 1 year. And during that year, the number of new episodes of DVT or pulmonary embolism was tabulated. It turned out that both groups of the rivaroxaban patients, whether it was 10 milligrams or 20 milligrams, had a 70% lower rate of recurrent DVT or pulmonary embolism than low-dose aspirin. So low-dose aspirin was the loser in the trial EINSTEIN CHOICE. What about bleeding complications? It turned out that the rate of major bleeding complications among the 3 different groups, low-dose aspirin, rivaroxaban 20 milligrams a day, and rivaroxaban 10 milligrams a day, was not statistically significantly different among any of the 3 groups. And rivaroxaban lowered by 70% the rate of recurrent DVT and pulmonary embolism that 70% lowering compared with low-dose aspirin held true not only for the patients with out-of-the-blue, unprovoked DVT and pulmonary embolism, but it also held true for patients with a provoked DVT or pulmonary embolism. And this is a major finding because it had been speculated that low-dose aspirin might be the best, most safe and effective way to continue to treat patients with DVT or pulmonary embolism, but Einstein Choice showed that either of the two doses of rivaroxaban was much more effective than aspirin and equally safe. Where does this leave us now? Now, we don't have any new guidelines yet based on this trial, which was published less than a year ago in the New England Journal of Medicine. And I think we're in a changing environment where doctors are going to have to talk with their patients and individualize the duration of anticoagulation. Certainly, if you decide to continue anticoagulation, it appears for most patients that you might as well go to the lower dose of rivaroxaban since it was equally effective and had a slight non-statistically significant difference in being slightly safer than the 20 milligrams of rivaroxaban. But we don't have any other trials yet on this topic, and we're in an era of uncertainty, but what we do know is that for many patients, they'll be at risk for a second DVT or pulmonary embolism, regardless of whether the first event was provoked or unprovoked, and that low-dose aspirin will not necessarily be sufficient to prevent a second episode. So this is Dr. Sam Goldhaber signing off for the Clot Chronicles.